guideline-directed medical therapy in heart failure. The war against heart failure, are we winning at this point in time? And it's very important. I'll show to you that probably we are on the path where we are able to come up with a good solution for patients with heart failure. And that is with the guideline-directed medical therapy. You had excellent lectures from Dr. Abed Amin on the two sides of the coin, diabetes and heart failure, and where he talked about these SGLT2 inhibitors, ARNI, and similarly Asad also, an excellent presentation with the in-hospital starting of ARNI, which is very important. And the reason for that is that whatever you will start within the hospital, patients are going to take that medicine. So I think that is from where we should actually start with our patients so that they understand that this is the regimen which is going to be useful for them. Now, this is the review which was written by Dr. Braunwald, and that was in 2015. After that, we have had a number of positive trials: Paradigm heart failure, Pioneer heart failure, Transition, then you had the Emperor reduced, the DAPA heart failure, then the Deliver trial in heart failure with preserved ejection fraction, and the Emperor preserved. All these trials were positive trials which gave us a lot of armamentarium to treat our patients. You would be wondering why I have put this picture on the screen. The reason is that heart failure and cancer, they are nearly as deadly. But it is cancer which is taking a center stage. And there are a lot of funds which are being generated for cancer, and for heart failure is being ignored as a condition, because this is never, one of the slides which was shown by Asad, you saw it, that heart failure is never stable. It's a disease which continues downhill gradually, and that is what we have to remember. So a lot of patients with heart failure are worse off than cancer. So I think we need to create an awareness amongst our doctors, amongst the population, that the treatment of this deadly condition, it's a fatal condition which should be actually started at the right time. It should be initiated as early as possible, and there should be no clinical inertia in these patients. The fight, when we are fighting the war on heart failure, it is actually on two fronts. Heart failure with preserved ejection fraction, which is an ejection fraction of 40%, and heart failure with reduced ejection fraction, which is less than 40% ejection fraction. Then this is the first definition of heart failure, where a clinical syndrome caused by the inability of the heart to supply blood to meet tissue metabolic requirements. However, we have now come to this stage where heart failure encompasses a structural damage to the heart, then the biomarkers which are there, which have been raised, and also the signs and symptoms. They are important. That is now what is making the universal definition of heart failure. Last meeting here in the update, I talked about the 10 commandments, and I think it's important that we talk about it. For example, we have ARNI and ACE inhibitors. What I feel is ARNI should be the first line treatment, even though it's a 1B recommendation, but the benefits are tremendous in comparison to ACE inhibitors and the ARBs. The only reason it is 1B is because there is one randomized controlled trial which is showing it. So we need to have ARNI and ARNI as the first line treatment. And then Asmat was going to talk about the CRT, which is extremely important in patients with heart failure. In those patients where you have a QRS which is widened more than 150 milliseconds, this is the patient who is going to benefit from CRT. This is the patient who's going to benefit from ICD. And this is what we need to do apart from the guideline-directed medical therapy. This is what we need to start in our patients. And then you have the ICD here, the heart transplantation. Then in the last, we come over to the structural management with the mitral clip in these patients, and especially in those patients who have amyloidosis. These are the patients who are going to be treated by specific drugs. Now, what are the benefits of GDMT? Number one, it improves the cardiac function. That is extremely important. It improves the symptoms and function. It reduces urgent visits and hospitalization. You saw that with the trials Asad and Abid showed. And then the treatment increases survival. Why shouldn't we start these patients on these drugs, on the guideline-directed medical therapy, when we can have the advantages in these patients? This was in 2013 when we had the ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, and hydralazine, which were also giving benefits, but there was a residual increased risk in these patients, and there was more to be done for those patients with heart failure. I even remember treating my patients with prazosin as a venodilator and an arterial dilator, preload reduction and afterload reduction, and the benefit was there. However, now with the newer therapy, we have seen that the reductions are even better in these patients. These are all the positive trials that have been carried out in these patients which have shown the benefits. And I think that we should be cognizant of the fact that the wealth of data now is clearly showing that guideline-directed medical therapy is the way to go in these patients. The first time the Canadian Cardiology Society, they started with the horizontal starting of all these drugs, not sequential, simultaneous. And I'll go through some of the details there also. When you have ARNI, the beta blockers, you have MRAs and the SGLT2 inhibitors. And after that, you have drugs like ivabradine. Wherever you need to use them, you need to assess the clinical factors for additional intervention, and you'll be able to give the other drugs and also start these patients on CRT, ICD, mitral clip. All these patients, they will benefit from this. Their lifespan will be improved. The quality of life will be better. Then we had it in the European Society of Cardiology also, a similar management of the heart failure with reduced ejection fraction, a horizontal starting of all these drugs. So I think this is what we have to do. We need to go through the simultaneous initiation of all these drugs. In the American College of Cardiology also, they have the same starting. It's in a vertical manner, but it is basically saying the same thing, that you need to start all these drugs together and then go forward and add other drugs whenever they are needed in your patients. When you start these patients, the expert consensus decision pathway also shows the same. What you need to do is look at the heart rate, look at the blood pressure, look at creatinine, look at the chronic kidney disease, and accordingly, you will start or continue with these drugs. So that is how you're going to manage your patients. Now, when we talk about the drug layering in our patients, you will see that it is the heart rate, the blood pressure, which we have to keep in mind, and renal dysfunction. This is how you're going to monitor your patients with, by giving these drugs. Similarly, when you have patients who have decompensation, you need to put them on diuretics. Thank you very much. You need to put them on diuretics. Then once they are recompensed, then you start using the early post-discharge, which was shown with pioneer heart failure, and the chronic phase when you need to continue with the treatment intensity in these patients. But what you need to see is the heart rate, the blood pressure, serum creatinine, and the kidney functions. They are important when you're giving your patient these drugs. If you look at this particular meta-analysis, you will see that as you increase these therapies, within 24-month mortality is reduced. So why should we not start these drugs in our patients? Then, if you, the event-free survival, which was shown in a 65-year-old patient, you will see that with the conventional therapy, this was the result. And with the comprehensive therapy, that the guideline-directed medical therapy, you will find that the patient will have a 6.3-year survival in our patient. Thank you very much. So basically, this is what you saw, what Abid talked about, that with the SGLT2 inhibitors in DAPA heart failure and Emperor reduced, you find the similar graphs here. And there is a 15 to 20% reduction in death. Also, as far as the hospitalization is concerned, there is again a 25 to 30% reduction. Very important, very helpful for your patients. And the side effects are very rare, so you don't have to worry about them. When you give these drugs together, they are additive to your patients. They help your patients more together than alone. But you remember that in your patients who have heart failure, in the advanced stage, they have more comorbid conditions. And with these comorbid conditions, you need to give them other drugs as well. And by and large, what we have all seen is that the prescription contains about 8 to 9 drugs in these patients with heart failure. So you have to be very careful when you are actually treating your patients and their comorbid conditions. This is the high-value treatment, ARNI, beta blocker, MRA, SGLT2 inhibitors, and when there is congestion, you will use the loop diuretics in your patients. Whenever you are thinking about treating your patients, look at your hand. The thumb is for euvolemia, loop diuretics. The index finger, evidence-based beta blockers. Then ARNI. Then you have the MRAs and the SGLT2 inhibitors. Think of them. Think of your hand when you're treating your patients, because then you'll be able to treat your patients in a much better scientific manner. Then in hospital, you can start these drugs. It is okay. Pioneer has shown, as Asad showed us, the beta blockers with impact, MRA with Athenia, and SGLT2 inhibitors, the impulse trial. You have the CRT in your patients and ICD. You can add these whenever it is needed. If the heart rate still doesn't come down because of the beta blockers, add ivabradine. And in the black, self-declared black people, you start with hydralazine and isosorbide dinitrate. Above all, exercise rehabilitation is very important for your patients. Especially, you'll have to have a multi-professional disease management. You cannot treat your patients alone in patients with heart failure. When you look at the guidelines, once again, we think about how we are going to treat our patients and to what dosage we can go to. I'll show that to you in just a minute. When we look at ARNI for heart failure with mildly reduced ejection fraction and preserved ejection fraction, just look at this graph here. And what we think is that it is important that in this group of patients, 40 to 45 ejection fraction, less than 60%, you can use ARNI in your patients. You can use ARNI in your patients with heart failure with reduced ejection fraction, and you can use them in your patients less than 60%, those who have heart failure with preserved ejection fraction. This is the Emperor Preserved, which was clearly showing the benefits in your patient. These are the guidelines for heart failure with preserved ejection fraction. As I talked with you earlier, the heart rate is important, blood pressure is important, the chronic kidney function is important, and it's a personalized approach that you have to take. Whenever you're treating your patients with heart failure, you have to actually, it is the patient who's sitting in front of you, you are treating, and that is how you will go about it. The drugs that you give to them, the dosage, I'll show to you what we will be doing in these patients. For example, you will realize that what are the drugs which reduce the blood pressure. you'll take care of them. If the blood pressure is low, you need to reduce these drugs in your patients. And if the patient profile which I showed to you, in such a patient you will start with SGLT2 inhibitors and MRAs. If blood pressure allows you, ARNI, and then ivermectin if the heart rate is more than 70%. You see, we all have a bank with us. It's a bank where you have the blood pressure, it's the bank that you have the heart rate, it's the bank that you have the renal function, and it's the financial bank also. So treat your patients according to what the patient has. The blood pressure, heart rate, the electrolytes, the kidney function, and if the patient can afford it. This is extremely important.
Sir,
and
time
probably,
to
just give me two.
Of course, sir.
Can you give me 1 minute?
Sir, 2 minutes. तीन ले लें आप ऐसे
Okay,
क्या बात?
okay, thank you, thank you. So there are 5 pathways you have. You have the angiotensin 2, norepinephrine, aldosterone, neprilysin, and SGLT2. And then you have 4 drugs, remember, to treat your patients with. Beta blockers, MRAs, SGLT2 inhibitors, ARNI. And there are 3 others, ivermectin, hydralazine, and vericiguat. So this is what you have to keep in mind. 5 symptoms to be attacked by 4 drugs with 3 additional drugs that you have in your patients. So the pharmacological treatment for heart failure, these are all the trials which were done in reduced ejection fraction patients with heart failure, and the benefits were there. Then you have those with mildly reduced ejection fraction, beta blockers, MRAs. You can use ARNI. You can use the SGLT2 inhibitors according to Emperor and Deliver. The most important thing is that basically we are unable to implement the medical therapy. There are challenges, and the reason for that is that we have a clinical inertia. We always think that my patient is stable on current therapy, why should I change anything? He or she has mild heart failure. There is never a mild heart failure, and it is inconvenient for him. It is more work for me. So I think we have to get over this clinical inertia, a major threat to our patient. That is what it is. We should be complacent. Our patients deserve better. The sooner we act, the better it is. It should not be one day we will start the treatment. It should be started from day 1. This is important. This is my take-home message for you. I showed you the first slide where we had the slide about cancer. This is how you treat patients with cancer. Induction therapy, SGLT2 inhibitors, ARNI, beta blockers, MRAs. Then you have the consolidation therapy, add-on therapy, hydralazine, ICD, CRTD, and then you treat the comorbidities. This is what you should remember. And we always talked about the 4 pillars in the treatment of patients with heart failure. General Suhail, we need to have the 5th one, the cardiac rehabilitation. And that is how we are going to treat our patients. I think we are winning the war against heart failure, but there is still residual risk, and there's still a lot of things to be done. I'm grateful to Dr. Akhtar Bandeshah for giving me this opportunity, General Suhail for being patient with me, and Novartis for providing me with the logistics, and I'm grateful to Dr. Mohsen who helped me with the slides. Thank you very much.